Hi, my name's Andrew and welcome back to Coding Matters. Today we'll be talking about high quality nursing documentation and what that means for you as a nurse or someone that is in an allied health field. And I'll be joined by April Tay, who is a Clinical Documentation Improvement Officer and a former critical care nurse as well. In case you haven't heard of clinical coding or you're not sure exactly what that means, let's just do a brief recap about what clinical coding is and what it could mean for you as a nurse or other related field. So when a patient becomes admitted, and this clinical coding applies to many more spaces, but we'll just focus on the inpatient side. They are admitted, they have certain treatments, investigations, and then eventually they're discharged, either in a short or later time. And then there is clinical documentation that will reflect their journey and the different elements of the treatment management investigations that occurred during their inpatient stay. That documentation is then reviewed by a clinical coder. They're a person that is not a clinician usually, but someone who is trained to look through medical, nursing and allied health documentation and appropriately interpret them according to the system that they work in and the regulations that apply. And then they can summarise effectively the admission through the coded data. And in this case, within general hospitals, we use a group that's called DRGs. The reason that they get admitted gets put into one particular category that also has a certain complexity associated with that, which is determined by your documentation, which is why it's so important. Here are some of the elements that go into clinical coding. The actual diagnostic related group is determined by the principal diagnosis. So that's retrospectively the diagnosis which was the reason why they were admitted in the first place, whether emergency admission or by elective. And then we look at secondary diagnoses. There are events that occurred during the admission, similar to complications as well. Any particular procedures, whether they're therapeutic or diagnostic, and then any comorbidities that might have influenced the complexity of those complications or the procedures that were performed. Briefly, what is a diagnostic related group? It's related to the principal diagnoses and these other elements that we talked about before. So you need to have a principal diagnosis, the other factors that determines a DRG and the complexity, and that will determine activity-based funding amongst many other things that we'll talk about in a second. What are the real benefits or what are the outcomes of good quality clinical coding, which is informed by high quality documentation? Well, the funding is one really important part that's easy to measure, and we'll talk about some examples of that. But there are other really important elements as well. There's quality and safety, there's continuity of care, and there's also clinical performance. So how we measure ourselves as a team, as a hospital, as a network is informed by our documentation and the coding that comes from it. And whenever we want to do research or auditing our performance, those audits and that research is made so much more easy by effective coding and quality documentation in the first place. Now, you might feel as a nurse that some of your documentation doesn't get looked at, or somehow the medical documentation is more important. And for sure, there are some elements that there is some truth to that statement, but it's not true in completeness. Let's be honest, the principal diagnosis is almost exclusively informed by medical documentation. But when it comes to secondary diagnoses, complications, even some procedures and comorbidities, the documentation by you as a nurse is almost as important as a doctor, and in some cases is actually much more important in contributing to that complexity. So at this point, I'd like to welcome April Tay to the video. Thanks for joining us, April.
Thank you. Thank you for having me.
Pleasure. What would you want to say about high quality nursing documentation to our colleagues?
Yeah, so for me, as a nurse, high quality nursing documentation should adhere to the ACS-QH Standard 6, so that's your communication for safety. So clinical documentation should be accurate. It should reflect your assessment, the plans or nursing interventions that you have done, and also it needs to be accurate and contemporaneous and up to date as well. That's it really.
Yeah, and that's really, they're good points, not just for nursing, but actually for all clinician documentation.
Absolutely.
Yeah. So April and I, with our team, we've put together 3 main takeaways of really easy but very valuable improvements to nursing documentation that we're going to go through now. The first one is documenting purpose and reasoning. And I've got to say, as doctors, we can also improve on this. So it's not just a nursing improvement. I think all of us clinicians can improve on this. So this is where we're linking treatment interventions with diagnoses and within the care plan. So always the idea of connecting, I have done this or this has happened, because of this diagnosis, because of this condition. And so putting things like, why was a scan done? So rather than I escorted the patient to radiology for a CT, just adding on to investigate pulmonary embolism, to investigate shortness of breath. That linkage between the action and the reason is really powerful when it comes to documentation, not just for coding, but actually understanding the patient journey at all points. So if anyone were to look back, we can understand the purpose of that. I think also, even basic things like medications and saying that we have, critical care, we have commenced noradrenaline for blood pressure support related to sepsis. It's just linking those really basic things. As clinicians, we're often thinking it,
yes,
but we don't actually write it.
Absolutely. And in a nursing point of view as well, there's different nurses who are in different wards who have varying backgrounds. So there might be nursing students who have limited knowledge about a certain procedure or a certain medication. So it would be really helpful for them to have that diagnosis and plan being linked. It's for patient safety too. So basically, as nurses, I ask myself, why am I doing this? So for example, one patient is on has a stat furosemide. I ask myself, why am I giving this? Probably because this patient has got an APO or that sort of thing. Yeah.
And I think sometimes it's fair to say that we don't always know 100%. So sometimes it's for
Absolutely.
Suspected or likely.
Yeah.
And that's okay, because you're not making the call to diagnose them with something.
Yes.
You're just putting forward that reasoning that you have as a clinician.
Absolutely. Yeah. Because as nurses, we're not diagnosing anything. But through our assessment, we sort of have an idea or a background of what is happening to the patient. And then that's when we escalate to the doctors if we are concerned about something.
Yeah, absolutely. And there's a good point as well of saying that last line about what if something didn't happen. That's really important. And I'd say usually the nurses are the best informed about why things don't happen at a certain time. So, Tazocin was not given on time due to visitors and the patient insisting on going out of the room, or this intervention was delayed because there was a scan that occurred at the same time. So as we look back, we can go, no, there were good reasons why things maybe didn't occur as per the standard protocol.
Absolutely.
So the second point, which is we've alluded to as well, is about being really specific with our diagnostic terminology. And this is, again, not just a nursing issue. This is a doctor's issue. This is an allied health issue. It's an everyone issue, where we're using a lot of assumed terms. And we know what that means, but if we don't write it in the way that it can actually be recorded and understood by all parties, then we are really doing a disservice through our documentation. I mean, what are some of the terms that you think of as a nurse going, we probably should do that more specifically?
Consolidation of the right lower lobe, that sort of thing, or dry mucosa. That's about it really that I could think of.
Yeah, another common one I think between doctors and nurses is confusion.
Yeah.
Often say the patient is confused.
Mm-hmm.
Why could the patient be confused? Is this a baseline confusion related to their known dementia? Or is this a new confusion where we could probably label it as delirium for investigation? And that will, lead on to a number of investigations to try and get to the bottom of it. So using, we say confusion, we are thinking delirium. Let's actually write it. We say low blood pressure. What we really need to use is hypotension. So a shift from using terms that are more related to data, symptoms and signs into diagnoses, not because you are making the diagnosis, but because diagnostic terminology is important for everyone to understand the process that we're working with.
So your documentation is not only used by just us clinicians, there are a few people who use it for other reasons. So your documentation is not just for patient safety, it's also used for other things like for benchmarking, your activity-based funding, your national safety quality health indicators. So some of the people who utilize it don't necessarily have a clinical background.
Absolutely.
And that would be, your clinical coders. So we would like to have that specificity of some diagnostic terms as well.
Absolutely. And I've come to appreciate more this year that coders and health information managers are very much restricted on the terms that they can use to code and understand what happens on the ward. But we as clinicians have a broad vocabulary and the ability to choose different terms to document. And so we need to be the ones who are actually aligning with the coders because they don't have room to move. They are working in a reasonably tightly regulated and inflexible system, and sometimes that system doesn't reflect 100% the words that we're using contemporaneously on the ward, so we need to be the flexible ones to make those small adjustments.
Correct, I agree.
I think along that as well, like we use so many abbreviations and acronyms, probably too much, and we really need to try and spell things out in full. Sometimes it takes more time. If you're working in an electronic medical system like we are here in South Australia, you can use acronym expansions, or in Epic and Cerner you can use smart text to actually automate those things, so that whenever I write AML, it automatically spells out acute myeloid leukemia, so that those colleagues of mine or coders that maybe are unfamiliar with hematological disorders will not be left guessing. They'll know exactly what I've written. And I think we can do very similar things in the nursing context as well.
Absolutely, yeah. So we utilise those sort of acronym expansions as well. Yeah.
There are some commonly understood acronyms. I think there's even a national list that's available somewhere. We should try and find the link for that one for you. But please try and avoid making up your own custom abbreviations and acronyms, because that can be very, very confusing for not just our clinician colleagues, but for the coders that are trying to decipher exactly what you meant by what you wrote. So try and keep it written in full, or just to a small number of commonly understood acronyms. We alluded to this before, but you're allowed to express some uncertainty related to diagnostic terminology. So I think about in my hematological context, we have a lot of patients that have fevers. Febrile neutropenia is a diagnosis, and of course it is the doctor's primary responsibility to make that diagnosis, but I've got some very skilled nurses that are well experienced in my area that could definitely contribute to that diagnosis in a meaningful way. So when they see that they're neutropenic and the person now has a fever, they can write, I have contacted the doctor, I observed this fever, they have these symptoms, I've taken these OBS, I have contacted the doctor, I have a concern for febrile neutropenia, or I think that febrile neutropenia is likely and I've initiated a review and taken cultures. So again, linking that action and that clinical data to a diagnostic statement. You don't have to be the one making the diagnosis, you can be expressing concern or probability that that may be the diagnosis we're working towards.
Yeah. So as nurses as well, we tend to see the patient quite often. So it's really good that if you're concerned about something and you've escalated to the doctor, please reflect it in your documentation. That I've highlighted to this doctor that this patient is suddenly tachypnic or has a new confusion, and hopefully you can reflect what time it was or who you spoke to as well, and what nursing interventions you have done for it.
Yeah, often I, as a doctor, am looking back to go, when did this start? Which I'm linking with the diagnosis we've made. And as nurses, your documentation is usually the most valuable when it comes to timing and identifying, which symptom or sign was the initial point of concern, which then later led to the diagnosis. So thank you, and please keep doing that high quality documentation. The last point, which we've alluded to already, is about using diagnostic terms and making assessments. I've heard it said by many nurses, I'm a nurse, I don't make diagnoses. And there is some truth and some fallacy to that. So as nurses, you are clinicians and you are able to make diagnoses, especially within your scope of practice, which varies across different nurses. So I talked about hematological nurses, that they are able to make diagnoses and contribute to things like febrile neutropenia and transfusion reactions and chemotherapy reactions. That's bread and butter of what we do. I mean, as a critical care nurse, you would also be contributing to diagnoses within your scope of practice.
Absolutely. So that's why patients are in ICU, because they're critically ill. So there's usually like signs and symptoms when the patient sort of deteriorates. So in ICU, we have arterial lines. So we sometimes take blood gases and we can interpret it from there because it gives us values. Like, for example, the potassium is, let's say, 2.8, and the patient has becoming symptomatic with it because they're having PVCs. So we could say, we know that the patient's hyperkalemic, and then we can escalate it to the doctor, and hopefully they'll get treatment in the form of some potassium replacement. Yeah.
Absolutely. And you can see that the potassium is low. You can write hypokalemia, and you can link that with whatever the likely cause is, excess fluid use or diarrhea, whatever it is that's contributing, and likewise with those ECG changes that you're seeing. And I know that you and your colleagues are very skilled at interpreting blood gases and managing people on ventilation. So knowing about type 1 and type 2 respiratory failure would be within your scope of practice as well.
Yes.
That may not be within many other nurses' scope of practice.
Correct, that's very correct.
And I have to say, I really appreciate the wound care that many nurses are well trained in, particularly some of ours that are linked with the plastics team in our hospital. You provide a skill set that is much greater than most doctors. And so that kind of diagnostic terminology in there regarding wound care and potential infections and what needs to be done as a management is really, really valuable and very much adding to the complexity. We've included some examples there, and even for our midwife colleagues, the scope of practice, you think around delivery and birth and diagnosing a postpartum hemorrhage, concern for a postpartum hemorrhage. Those are all the kind of terms that we should be using as we work together as a team.
And also I'd like to add as well, for nurses to pressure injuries, so it's within our scope to actually have a look at a patient's skin and assess what stage that pressure injury is, and if it needs escalation, then we can highlight it to the doctors or to a SWAT nurse perhaps. Yeah.
Absolutely, very important role.
My name is Trudy Smith-Sparrow. I'm the NALHN Divisional Director of Nursing for the Division of Medicine. I think it should be encouraged. The nurses really have a focus on doing the signs and symptoms of what they see in their observations, both actual observations and in their visual. So we would really encourage our nurses to be using the right diagnostic terms and what they see and what their concerns are, both in their documentation and in their ISBAR handovers. For a pressure injury, for example, they might see some changes in the wound presentation, some slough or some other signs of redness around the wound, and we would expect them to do the observations and look for temperatures or any changes in the patient's condition, and then document that accordingly, that they might be seeing some early signs of infection. So the nurses don't diagnose, and we don't diagnose, we don't discharge, so there's certain things we don't do within our scope. But we do work within the team, and we do see changes, and we would have a reasonable assumption of what is happening with that patient. So although we wouldn't diagnose, we would still use the right terminology, in that if we're seeing early signs of infection, of sepsis, of a urinary tract infection, we would use that terminology when we're discussing it. We're not saying they have a urinary tract infection, but we're seeing the signs of an early infection, some changes in the patient's behaviour with their observations, their temperature, and we would definitely use that terminology, in that we could be suspicious of a urinary tract infection. We wouldn't be saying the patient has a urinary tract infection. Like we've spoken about, it's that terminology that we all need to be using the same terminology in that, like we spoke about, a urinary tract infection, some signs of infection or sepsis, and that we're using that terminology all the time. Like the nurses, many of them are very senior and know exactly what their probably diagnosis is going to be. We wouldn't diagnose, and the nurses are very clear about their scope of practice, but we all need to use that terminology, because that's really developing our younger nurses. We've got a junior cohort of nurses, it's developing them to use the right terminology in all of their documentation and all of their communication.
I've included some examples there for nurses as well as midwives, and on this second slide you can see there's examples of areas within scope of practice for other allied health colleagues of ours, just showing that each of us has something valuable that we can contribute to patient care and high quality documentation, and it really meaningfully impacts the complexity of the way that they're coded, and therefore many of the elements of what we're working with is reliant upon our quality documentation. So thanks for joining me, April.
Thank you.
And just to summarise, we've got three key improvement areas for nursing colleagues. One is being able to document purpose and reasoning, and that's linking actions and interventions with the condition or diagnosis, using specific diagnostic terminology rather than symptoms and signs and impressions. Don't make assumptions, document explicitly. And lastly, documenting assessments and diagnoses, particularly if it's within your scope of practice in your particular area as a nurse. So thanks for watching, and we're looking forward to reading your high quality documentation soon.